Stem cells and stem cell therapy are an emerging worldwide technology that has tremendous potential for mankind. As physicians and people that work in this industry, we have a responsibility to appropriately handle this precious technology. And the basis for that is education. Today, I'll talk briefly about the history of stem cells, but then really get into the function and the science behind how stem cells work. Do a little comparative analysis between adipose bone marrow and umbilical cord stem cells, though I won't be spending much time on amniotic fluid or placental tissue because based on how they must be processed, they really don't have any live stem cells anyway. So people tend to think that stem cells are this brand new phenomena that landed on Mother Earth in the last few years, but that's really not true. Stem cells were first initially discovered by Friedenstein in the 1950s. He discovered that these very special cells had the ability to differentiate into mineralizing cells, adipocytes, and chondrocytes. Well, by 1968, the first successful bone marrow transplant took place, treating two siblings with severe combined immunodeficiency. By 1978, stem cells were discovered in cord blood, and by the 1980s, UCLA, working in conjunction with Penn State University, discovered stem cells in adipose tissue. Within just a few years, stem cells were discovered in every tissue in our body, and the race was on. For completeness, I want to talk about the different types of transplants that are available, and that would include stem cells. Number one, you have autologous type transplant, which is taken from your body and put back into your body. Number two would be allogeneic transplant, taken from someone of the same species and put into your body, such as that bone marrow transplant. And then the third type is called a xenograft. It's taken from a different species and put into your body. An example of that would be in the early days when they did heart valve transplants. They used heart valves from pigs and put them into human bodies. They had to take immunosuppressives the rest of their life, but it worked very well and it saved their life. The International Society for Cellular Therapy has a definition of what something must be in order to be a purified stem cell. Now understand, the stem cells we deal with, whether they're BMAC or they're adipose or they're umbilical cord blood cells, are not purified cells. They're a heterogeneous mix of all sorts of different cells. But for the sake of completeness, the International Society for Cellular Therapy has a definition of purified stem cells. Number one, they must be adherent to plastic in clinical conditions in the lab. Number two, they must contain CD105, CD73, and CD90. If you're not familiar with CDs, they're cellular differentiators on a cell. On every single cell in our body, there are approximately 339 cellular differentiators that all have a different function in our body. As an example, CD34 makes cartilage. CD56 is a natural killer cell. CD90 identifies the cellular components of a stem cell. CD73 is specific for tumor suppression. CD105 has to do with our hematopoietic stem cells, and the list goes on and on and on. So these are some of the criteria for a stem cell. The third criteria is that they must be able to differentiate into osteoblasts, bone, adipocytes, fat, and chondrocytes, cartilage. So those are the basic criteria set up by the International Society for Cellular Therapy for a purified stem cell. For our purposes, what we are looking for in cord blood stem cells, they have two minimum qualities. Number one, stem cells are renewable. That means they have the ability to undergo mitosis and have the potential to duplicate. Umbilical cord stem cells had the potential to duplicate approximately every 28 hours in the lab. Second quality is that stem cells have potency. In stem cell language, potency is not strength. Potency is defined as the ability to differentiate into any cell in the body. So, umbilical cord cells have the potential to duplicate every 24 hours for up to 90 generations in vitro in the lab. There's some controversy about this now as to whether or not stem cells actually duplicate in their body. However, if you look at the fact that, as we age, our concentration of stem cells in our body diminishes, it doesn't make sense that they have the ability to duplicate. So we'll go with the majority of the thinking that says that stem cells do not duplicate in our body. However, they have the potential to duplicate in the lab. Now, that's umbilical cord stem cells. Bone marrow and adipose tissue stem cells also have the ability to duplicate in the lab, though it is significantly slower just due to the fact that the cells are significantly older. A typical 50-year-old BMAC or adipose cell has the potential to duplicate in the lab approximately every 3 to 5 days, and studies have shown that they will do that between 11 and 13 times. Compared to umbilical cord cells, which can duplicate every 28 hours for anywhere from 65 to 90 times. What's also important when talking about bone marrow and adipose-derived stem cells is that past the age of 60, it's very common to have an autoimmune disorder. And we know that autoimmune disorders damage our stem cells. So, what is the actual function of a mesenchymal stem cell, or a stem cell that we're talking about? So, we believe that they do not duplicate in the body or in vivo. However, they do produce long-term effects by responding to signals from injured tissues, and they do this in multiple ways. Among the primary effect is modulating the inflammatory and immune response to that injury. These responses are frequently excessive, and they contribute to the pathologic changes that follow. So these MSCs will secrete anti-inflammatory, immunomodulatory factors, including such things as TSG6, PGE2, TIMP2, interleukin-1RA, and they synthesize various growth factors, cytokines, exosomes, and microRNAs. And these are some of the things that we're going to talk about right now. So what do stem cells actually secrete? Well, we spoke about TSG6. This is a very short acronym for a very long word, tumor necrosis factor alpha stimulated gene protein 6. Essentially what it does is blocks the downstream formation of tumor necrosis factor alpha. Tumor necrosis factor alpha is one of the most potent inflammatory components in our body, and it is indicated in many autoimmune diseases, and it correlates directly with disability, cognitive dysfunction, and death. So TSG6 inhibits the downstream formation of that. Another one, secretion of a mesenchymal stem cell is PGE2, prostaglandin E2. They help to suppress the T receptor cells, and they act in a downstream blunting of the inflammatory process. Another secretion is TIMP2. This is called tissue inhibitor of metalloproteinase 2. So it blocks MMP2 and 14. So it blocks the matrix of metalloproteinase 2 and 14. MMP2 and 14, what they do is break down type 4 collagen, and they reside in the extracellular matrix around the cell. So TIMP2 has the ability to block the formation of the matrix of metalloproteinase 2 and 14 so that it no longer degrades and breaks down type 4 collagen. Another major secretion by the mesenchymal stem cell is interleukin-1RA, stands for interleukin-1 receptor antagonist. Interleukin-1 is a very common pro-inflammatory that we see in injured tissue. Interleukin-1RA is able to blunt the signaling from interleukin-1 so that the inflammatory process does not take place. If you will look back at the three previous things that I mentioned, TSG6, PGE2, and TIMP2, they are all downstream inhibitors of inflammatory components. So patients may ask, when am I going to start having this tremendous anti-inflammatory response? Well, it may not happen immediately because 3 out of the 4 major secretions inhibit the new formation of these inflammatory components. It's only interleukin-1RA that actually acts actively in the joint to begin to stop the formation of the inflammatory component. And that's why it can take some time for the anti-inflammatory component to take place. There are other additional things that MSCs do, such as anti-apoptotic effect. Apoptosis, as we know, is programmed cell death. It literally means cell suicide. Well, umbilical cord cells have the ability to rescue apoptotic cells, cells that are going towards their death, whether it's induced by trauma or hypoxia or chemicals, and it has the ability to nourish them back to health, and that's called anti-apoptosis. Another major function of a stem cell is their antimicrobial effect. MSCs have a native immune defense against microbial infections, and they know it's due to different polypeptides that it stimulates. They believe it has mainly to do with one called LL37. But there are many clinical trials going on right now for the treatment of acute, chronic, and systemic infections. What's also interesting is that they have found that they are very effective against protozoa. So there's a lot of hope down the road for potential Lyme disease patients. So what do we know so far? MSCs duplicate themselves in the lab for sure, but we're not sure about in the body. MSCs do secrete anti-inflammatory and immunomodulatory factors, and they synthesize various growth factors, cytokines, exosomes, and microRNA. The most clinically relevant synthesized secretory factors are TSG6, PGE2, TIMP2, and interleukin-1RA. So what's next? Well, we now have the MSCs in this injured environment. They secrete their multiple anti-inflammatory factors that inhibit the inflammatory process. So essentially, these stem cells have optimized the environment around the damaged cells by inhibiting the inflammation. Now your own body, along with these umbilical cord cells, has the opportunity to begin to regenerate its own damaged tissue. These growth factors, cytokines, exosomes, and microRNAs from these umbilical cord cells can now begin to work with your own body to regenerate this damaged tissue. So we know that we have the stem cells. And I said earlier, this is not a purified stem cell product. It has heterogeneous cells. Well, what are some of those other cells? Some of the other cells are immune cells. Well, we talked about immunomodulation, activation of the T cells. Well, another component are mononucleated cells. What mononucleated cells do is create growth factors. We know there are hundreds, probably thousands of growth factors, but we've limited it to a certain number of clinically relevant growth factors that also happen. So of these growth factors, we'll just go through a few of them. A very important one is called VEGF, vascular endothelial growth factor. It's a protein produced by these cells, and it stimulates angiogenesis, production of blood vessels. This can be very vital in low vascular areas, such as chondrocytes in a joint. Well, someone will say, but cartilage doesn't have blood vessels. That's absolutely correct. But the bone underneath the cartilage has been damaged, and that's exactly why that cartilage is no longer functional. So it will help to rebuild those blood vessels below the cartilage in the bone so that now it has the capability to grow that cartilage on top of the bone. Another important growth factor is FGF2, fibroblast growth factor 2, one of the most powerful mitogens in our body. It encourages healthy cells to undergo mitosis and duplicate themselves and to begin to proliferate. Another important one are the immune cells, which we talked about immediately before. And they're regulatory T cells. They help to modulate the immune system. Well, you say, what immune system is going on inside my joint? Well, it's an imbalance of your T1, T2 helper cells. Because anytime you're in a pro-inflammatory environment, your T1 helper cells, interleukin 1, 2, 12, and in chronic inflammation, also interleukin 8, are significantly elevated, while your T2 helper cells are not coming up and balancing that out. These immune cells have that capability. Another secretion that's present is stem cell factor. This is big. Stem cell factor actually stimulates your own inactive stem cells in your body to migrate to the location. And these cells, since they're your own stem cells, have the capability to differentiate into new tissue. So if we look at that real simply, MSCs decrease inflammation. They bring in immune cells and help to balance the immune system. They have growth factors, those cells will secrete the growth factors, and they secrete stem cell factor, which stimulates our own cells to begin to heal ourselves. We also have endothelial progenitor cells. These are beautiful. It's an emerging technology. You're going to read a lot more about it. This is a stage of a cell directly after it's a stem cell prior to becoming a new cell. It's almost like a blank check. It's very exciting, and that technology is emerging. Fibroblasts, it secretes fibroblasts, which are the structural framework for all of tissue in our body. It secretes nerve growth factor, stimulates and regulates nerve growth. It secretes platelet-derived growth factor, which stimulates all cells, healthy cells, to grow, but it also regulates that cell division so you don't have an overproliferation of tissue. And it also secretes transforming growth factor beta, which is specific for the stimulation of chondrocyte growth. But again, it also regulates that chondrocyte growth and division so that you don't have overproliferation. So let's back it up and say, how does this actually work? Damaged cells put off a chemical signal in the space around them. That space is called the paracrine space. You may not be familiar with that, but you're probably familiar with the endocrine system in our body. The endocrine system in our body is the channel for chemicals and hormones to balance our body. And that's for our entire body. The paracrine system is just that area around each one of our cells. So when a cell is damaged, it puts off a chemical signal in that paracrine space. It's like their little white SOS flag. Now, with umbilical cord cells, when they go into our body, are attracted to that chemical signal. They will come up next to it, and they will dock in what's called a lock and key type mechanism, and they become a periocyte. As a periocyte, they will now give trophic support or nutritional support to that damaged cell and bring it back into health. And that is called paracrine signaling. So, just to review, when umbilical cord cells are injected into the body, MSCs secrete anti-inflammatory, immunomodulatory factors that optimize that local environment. The live nucleated cells now secrete growth factors that nurtures damaged tissue to become healthy and stimulates healthy tissue to undergo mitosis and to begin to duplicate itself. The live nucleated cells also secrete stem cell factor, which stimulates our endogenous stem cells to migrate to the damaged site. These endogenous stem cells that are from our own body do have the ability to differentiate into new tissue. So we've talked about all of these cells, these live nucleated cells. Why are we talking about live nucleated cells? Because live nucleated cells are important. Live nucleated cells will continue to secrete growth factors and related proteins for weeks and possibly months in the body. And MSCs are part of these live nucleated cells. Well, what products consistently have live nucleated cells? Umbilical cord stem cells obviously do. Bone marrow aspirate and adipose-derived mainly do. Remembering that bone marrow and adipose, the quantity and quality of that cell is definitely dependent upon the age and the health of that patient. Well, what about non-nucleated cells? What about non-live cells? What about dead cells? What are we talking about? We're talking about amniotic fluid and placental tissue. Do they have any value? Yes, they do. They have growth factors and proteins that will function for the half-life of that growth factor or protein, which could be anywhere from a few hours to several days. The bottom line is live nucleated cells can function for weeks and months in the body, setting off a cascade of this signaling that takes place. And it can go on for long periods of time, whereas non-live cells do not have that capability. So let's go through a few examples here. We know with bone marrow aspirate, as a baby, in bone marrow, approximately 1 out of every 10,000 cells in our body is a stem cell. By the time we're a teenager, that is already down to only 1 out of 100,000 cells is a stem cell. So by the time we're a teenager, we only have 10% of the stem cells that we did as a baby. It has to do with growth of organs and brain and bone and all that sort of thing. By age 50, that number drops to 1 out of every 400,000 cells as a stem cell. And by age 70 to 80, it's down to 1 out of about every 2 million cells is a stem cell. So let's take an example of a bone marrow aspirate. You do a bone marrow aspirate and you take 100 cc's of bone marrow aspirate. And on this particular day, all the stars are lined up, and this is a beautiful, healthy patient, 50-year-old patient, and you get 10 million cells per cc. Well, you drew 100 cc's times 10 million cells, you have 1 billion live cells. The patient is 50 years old. Divide that by 400,000, because we know by age 50, only 1 out of every 400,000 cells is a stem cell. And what you have is approximately 2,500 stem cells in a bone marrow aspirate of 1 billion cells. Does that mean it doesn't work? No, it really doesn't, because stem cells are not everything. But the point being, it's not a big stretch of the imagination to understand that at 9 months old, you have a higher concentration and a better quality of cell than you do at 50, 60, or 70 years old. Let's take that same example of umbilical cord blood. We know that in umbilical cord blood, anywhere from 1 to 3, maybe 4% of those cells are actually mesenchymal stem cells. In the Livion product, we've tested it multiple times, and it averages approximately 3.2%. So if we took our intra-articular injection of 10 million live nucleated cells, multiply that times 3%, we get 300,000 stem cells, compared to approximately 2,500 stem cells in the bone marrow aspirate. There are other advantages to using umbilical cord stem cells. As we just discussed, they contain an abundant supply of mesenchymal stem cells. Importantly, there's no need to collect them through invasive procedures such as liposuction or a bone marrow collection. And umbilical cord stem cells proliferate and differentiate in vitro more efficiently than other types of stem cells, and therefore are considered to be more potent. There's been a lot of analysis comparing umbilical cord cells to autologous cells, which would be bone marrow and adipose and amniotic cells. But we've really covered most of that. All of this testing has been done in vitro because it's through the International Society of Molecular Biology. And they will basically discuss simple things like the composition of umbilical cord versus amniotic versus autologous cells, or the type of cells involved. And it's all the stuff we've talked about. Bottom line is, amniotic fluid and placental tissue have very few, if any, live cells, just because how they must be processed according to regulations. And if we compare umbilical cord to autologous, by the time you reach 50 years old, your autologous cells have diminished in number so much that the International Society of Molecular Biology says they feel that they are basically ineffective at that point in time. So a comparison of umbilical cord versus autologous is very straightforward. The umbilical cord cells have a much higher quality cell and a higher concentration of cells. So one thing you have to be asking yourself is, what about safety? What about these cells going into our body? Well, what we know is that umbilical cord cells are naive. They're young. They do not contain the same cell markers as a mature adult cell. When the stem cells are removed from the cord blood, the stem cells no longer contain markers or proteins from that blood. There's special processes to remove the cells from the whole blood, and then there's a secondary process to remove all of the proteins that came from those lysed red blood cells, so that you do not have those proteins or markers on that cell. And that special process is called glycophorus A columnization, that removes all the HLA-DR, which is an MHC class II antigen. And then these processed umbilical cord cells are then considered immune privileged. And you'll get the question, what about, can it cause graft versus host disease? Ironically, graft versus host disease in pediatric leukemia patients is one of the approved intravenous applications of stem cells in the United States. If you need further background on what's going on, or you have a problem sleeping at night, you can always go to clinicaltrials.gov. They have probably between 5,000 and 6,000 clinical trials that are currently being conducted, and it can give you an idea of some of the studies that are going on out there. For sake of completeness, I think it's also good to review the fact of where the cords come from. These cords typically come from a prepared cesarean section, a pre-planned cesarean section. So when approximately 1 month before the baby is born, mama goes to the OBGYN, and the OBGYN asks mama if she wants to keep the cord for her own baby. Less than 10% ever do, and it's probably just a cost factor. If they're not going to keep it for their own baby, then they're asked if they would like to donate it. If they say yes, then they have to undergo screening according to the American Association of Tissue Bank, just as if you were going to donate bone marrow. If they pass that, then at the time of the planned cesarean section, a technician takes the umbilical cord at the time of birth, takes it into a separate room, drains the venous umbilical cord blood into a bag, delivers it to our lab. When it reaches our lab, they mechanically separate the stem cells from the cord blood. Then they do a secondary procedure called the glycophorus A colonization, where all of the red blood cell proteins that were left are completely removed. And then they send a sample of that to a third-party independent lab, which tests according to USP Rule 71, that's United States Pharmacopoeia Rule 71, for communicable disease and for sterility. Those stem cells are then placed in isolation or quarantine. Only and only when we have back a cleared report from the American Association of Tissue Bank and this USP Rule 71 can these cells be made available for human consumption. It is at that point in time that we can bring them out and make them available to you. The other thing that we will deal with mostly are the FDA guidelines. A lot of you get questions about what's going on with the FDA and how is it regulated. Well, it's called Title 21, Code of Federal Regulations 1271, Section 361. It's very straightforward stuff, and it's very easy to explain. Basically, there are 4 criteria that we need to meet. Number 1, must be intended for homologous use as determined by labeling and advertising. Homologous use means that it's the same thing that these cells do in the body. Well, that works, and that's exactly what these cells do, is anti-inflammatory, immunomodulatory effects. Number 2, be only minimally manipulated in manufacture. Ours is a complete mechanical procedure. It is considered minimal manipulation. Number 3, cannot involve the combination with any other products other than for sterilization or cryopreservation, and we fall into that category. And number 4, not have a systemic effect and not be dependent upon the metabolic activity of other living cells, and we fall into that criteria. So we firmly fall under Title 21, Code of Federal Regulations 1271, Section 361.